Support for UWTV is provided by the Boeing Employees Credit Union.
My mom used to be a special ed teacher, and when I was little, maybe about 1 or 2, she just noticed that certain things I was doing was kind of slow, and she didn't really think anything of it. And then my parents went and saw a specialist, and they kind of thought that maybe something was off, so I had a biopsy when I was 3, and that's how they found out I had muscular dystrophy. But it doesn't really manifest itself till you're around 11, 12. So as a little kid, I was pretty normal. Just maybe if I fell down, it took a little longer to get up. Like in 4th grade, I can remember Jim having to back up against a wall to kind of get me up. And then the other thing is you kind of start walking with your back arched. That's kind of balance. Anyway, so about 5th grade is when I actually couldn't walk anymore. So I started using a chair in 5th grade, and a push chair, a manual chair, up until I was 12. And then I went to a power chair because I couldn't push myself around, and I was able to feed myself. And then eventually that became harder and harder. And that went on until I was about 23, and then from then on I started needing it. I started having somebody feed me, and then so that was the next thing. And then the thing they talked about after that was my breathing, because that's kind of the next muscle group they worry about.
Hi, welcome to Talk Medicine. My name is Dr. Joshua Benditt. I am a pulmonary and critical care physician at the University of Washington Medical Center. I am the medical director of the Northwest Assisted Breathing Center, and today we're going to be talking about respiratory care of patients with neuromuscular disease, focusing on non-invasive assisted breathing. I'd like to welcome a friend and patient of mine named Jesse Watson, who is a young man, now 31 years old, with Duchenne muscular dystrophy. And for those of you who do not know, Duchenne muscular dystrophy is a genetic disease that affects the muscles and causes weakness, including weakness of the breathing muscles. Welcome, Jesse.
Thank you.
We first met about 10 years ago, and can you tell us what was going on with you at that time in terms of your breathing?
I just finished with a bout of pneumonia, and switched over from Children's Hospital to the U, and found you through my rehab doctor.
Okay. Were you hospitalized with the pneumonia?
For about a week.
For about a week.
Yes, I was, and so that kind of was an indicator that something might have been happening with my breathing.
Okay. And were you on any breathing support devices at that time or not?
Not at the time.
Not at the time. Okay. So you were starting to have problems with breathing, and not only breathing, getting air in and out of the lungs, but also coughing. Is that right?
Mm-hmm. I had a little harder time breathing. I'm just getting air in general, and my coughing was quieter than it used to be. And I was having some trouble at night. I'm waking up a little more frequently than usual, and other things like that.
Okay. And before we move on with the non-invasive assisted breathing, Can you tell them what you're actually using there? What is that mouthpiece that you're using?
Well, like you said, this is called non-invasive assisted breathing. And basically I use a ventilator in the back that pulls in outside air and forces it down into my lungs to inflate them more than I can on my own.
Okay. So it's really taking over breathing for you when your muscles are weak.
Yeah.
Okay. Doesn't have oxygen or anything like that.
No, just air.
Okay.
Just regular air.
Great. So when you came to see us, we started doing some breathing testing on your muscles to see how your cough was and how your breathing muscles were. What did we start doing? Can you tell us a little bit about how we started treating you?
Yeah, after we did the test to figure out that I needed some help, we started with nighttime assisted breathing with a thing called a BiPAP, and used that for a couple of years. And then when other things started happening, we moved on to the next step,
Okay.
which was full-time assisted breathing.
Okay. So you're using a device at night to help you breathe, which is a nose mask, and then during the day you're using the mouthpiece. So two different pieces of equipment.
Yeah.
Okay. And you also use things to help you cough, is that right? Okay. And what are those devices?
There's a cough assist machine that helps me cough, just a bigger cough than I can normally, and a suction device that helps me with fluids and other stuff in my throat that I can't get up as easy as other people.
Okay. All right. So helping you to breathe, ventilate, cough, get secretions up and out of the airway, those two basic things. Jesse makes a really good point there about the different muscles that are involved in breathing problems, and I'm going to go through those in a little bit more detail. There are really two major groups that are involved in breathing function. Ones that control ventilation, that is getting air into and out of the lungs, and ones that allow patients to cough. In this slide, I show you the major muscles that are involved in ventilating or breathing, and those include the diaphragm, the external intercostal muscles, and what we call the accessory muscles of breathing, and these allow air to get into and out of the lungs. In this slide, I show you the muscles that are used in coughing, which are predominantly the abdominal muscles, but also include another set of the intercostal muscles known as the internal intercostals, and finally, the upper airway muscles that must coordinate during the cough maneuver. Now, I remember that at the time, before you came to see us, that you had to make a big decision about your breathing. Can you tell everyone a little bit more about that?
When I was at the hospital, I was at before the U, one of the last conversations I had with my doctor was basically two choices. One was a tracheostomy.
A tracheostomy is a surgical procedure where a tube is actually placed through an opening into the windpipe, and it allows connection of a breathing machine, a ventilator, and also suctioning of the airway. It's an invasive procedure, and it's what we would call invasive ventilation when it's connected to a ventilator.
What my doctor had said is basically you could choose between having that operation and not having any operation. And I had decided not to have one at the time because of all the medical procedures involved in really kind of cosmetic reasons.
Okay.
And then when I transferred over to the U and met you and found out that there was a different option to a tracheostomy, I really jumped at the chance to do it.
Okay. People should know that at that point, because these things were really just developing at that time period, the options for somebody like Jesse were kind of limited, and it was either to go ahead and have a tracheostomy and have a traditional ventilator, or do nothing, which actually would have meant that your breathing would have failed and you would have died.
So
and
this
it was
is a very nice compromise.
right, and I think because this has developed, and this is available at several places around the United States. It's not widely available, but it is, I think, as you say, a nice compromise because it allows you kind of the support that a tracheostomy, the life support, but without the complications that would include not only the cosmetic, but also issues related to bleeding and infection risk that come along with tracheostomy. So that was a hard decision. Thank you for sharing that with us. What's been happening more lately? How's your life been lately?
Not too different than before. We've had to adjust the breathing settings a little bit, just because it has been over 6 or 8 years, I think, since I started using this. But besides that, not much is different. I'm still pretty independent. And there really isn't anything I can't do.
Mm-hmm. Great. And you've not been hospitalized in the past 10 years since that last pneumonia?
Not since I've started using the non-invasive assisted breathing system.
Okay. And I was joking with your dad before, but it's hard for us to get you into clinic to get you back, and that's actually true with a lot of patients that I have, that once they get going on this kind of setup, they do great, they're independent. You've been able to go on vacation as well, is that right?
Mm-hmm.
Okay.
We go on different trips throughout the year.
Great. Well, thank you very much. I'd now like to move on, and we're going to look a little bit more closely at some of the devices that we can use to help people breathe in a non-invasive way.
BiPAP is a positive pressure breathing system. What it does is it constantly blows air into your lungs to keep them a little inflated. And then when you breathe in, it adds more air so you can get a deeper breath. But I think the purpose is to always keep your lungs open. So some of the things that are involved with the breathing is something called sleep apnea, where you actually stop breathing for a couple of seconds. And so BiPAPs help you not do that.
3 o'clock in the morning, he had a nightmare. And his nightmares always revolve around the fact that he can't breathe. So when I got in there, probably about 30 seconds after he called, he was in a great deal of distress. But I was able to bring that vent over to his bed, and that, along with the BiPAP, allowed him to kind of stabilize and wake up enough so that he could get things back to normal. It was just a nightmare, but it was quite real to him, and it goes back to that idea of being medically fragile. He wasn't able to recover from that on his own, and this machine has really helped. And the support, you know, from Dr. Benditt and Louis Boitano has been amazing.
Now I'd like to introduce to you a close colleague of mine at the University of Washington Medical Center. This is Louis Boitano, who is a respiratory care practitioner, who is going to show you about some of the devices that we use to non-invasively support breathing in patients like Jesse.
I'd like to talk about cough first, and when people present with some degree of weakness of cough that's not allowing them to clear the secretions as easily as they'd like, the first thing that we usually start with was the manual cough assist device. And this is just simply a resuscitator bag with a one-way valve right here and a mouthpiece at the end of the circuit that allows a patient to be able to take bigger breaths that they can take on their own. The way that it's used is by simply putting the mouthpiece in the mouth, and if the patient has the ability to do this, they can simply compress the bag on their own, or a caregiver can do this, to help them inflate the lungs as deeply as they can. Once they've done that, then they can simply cough on their own, and to be able to push that breath out, that deeper breath than they could take unto themselves, will allow them to cough more forcefully. Alternatively, you can combine the manual cough assist system with an abdominal thrust to be able to push the breath out more forcefully. So either by itself or in combination with an abdominal thrust, this manual cough assist device can be a good, effective way of cough augmentation. This is a good portable alternative. Jesse has a system that allows him to do this independently. Jesse, if you can show us.
Well, here's a regular cough. And then now I'll stack. can get a bigger cough.
And that's Jesse's ability to cough independently by using breath stacking with a mouthpiece system.
Now sometimes, for instance, if Jesse were to get a cold or respiratory tract infection, he might use a little bit more advanced system, which is called a cough assist, that would help him to clear secretions even better. Can you explain what that is?
The mechanical cough assist device simply mimics a cough by helping you to take a deeper breath than you can take on your own. And once it fills the lungs up with air, and you can set this to whatever level is necessary to help people take a deep breath, then it simply reverses the flow of air from positive to negative and pulls the air out forcefully to help pull the secretions out of the lungs. In effect, like a vacuum, but while it feels a little bit strange, it is actually quite effective, and most patients who use this find that when they do have a respiratory infection, that this is very effective for them, and they become quite bonded to it because they realize how well it can help them. So if you have something like a cough assist device and you have a respiratory infection that develops, the cough assist device in conjunction with antibiotic therapy can usually keep patients from having to be hospitalized for respiratory infections.
Great. So we have a portable cough device, we have the daytime ventilator that can actually help Jesse, and then this for respiratory infections. Now here are a couple of other devices. How does Jesse use these at home?
Well, these are two examples of bi-level pressure ventilators that can be used to provide augmented breathing support at night. This is what's called pressure support ventilation, and allows the patient to breathe by using either a nasal mask or an oral nasal mask. This is an example of an oral nasal mask where this plastic sheath with a gel insert fits over the nose, and then there's a cushion here for the forehead and headgear that allows the device to be on the head and comfortably fitted without too much pressure. The machine simply responds to your breathing pattern by helping you to take a deeper breath when you can take on your own, and then allowing you to exhale out. So it's augmentative, not a controlling device in terms of your breathing. Alternatively, for some people who cannot breathe well through the nose, you can actually use an oral nasal mask, and this is an example of an air cushion oral nasal mask. If a person were to have a respiratory infection that would not allow them to be able to breathe comfortably through the nose because of congestion, they could switch over to an oral nasal mask until that congestion is relieved, and then simply go back to the nasal mask. Many of our patients actually have more than one mask type, and they simply use whatever works for them at the time. So nasal congestion is not a limiting factor to using this. There are also oral devices that can be used so that you can take a breath in through the nose only. So there are many different types of interfaces that can be used to help us adapt to using this at night.
So these are the nighttime support devices that he would use. And then for daytime support, as we've already seen, he has a nice setup. Can you go through the setup that he has with us?
Jesse has a volume ventilator located on the back of his chair, and we try to place these as tightly against the back of the chair to allow maximal mobility in the home and out and about. This ventilator has a breathing circuit that would be the same as which would be used in a tracheostomy ventilation, but in this format we actually combine the breathing circuit with a mouthpiece at the end of this support arm that makes the mouthpiece immediate to Jesse so that he can take a breath at will. The benefit of this system is that all Jesse has to do is simply sip like he would sip on a straw. That triggers the ventilator to give him a breath whenever he wishes, so he can take a breath whenever he wants. So his breathing is supported to the degree that he wishes, and he is in complete control of that. Again, the other benefits to this are the ability to be able to breath stack by taking repeated sip efforts through the mouthpiece and holding the breath in your lungs. You can stack more breaths to hyperinflate the lungs and then simply cough more strongly than you could do independently without the support, or to actually keep the lungs inflated, because we all need to keep our lungs inflated well enough so that we don't develop lung collapse that can predispose us to respiratory infection. So this is really a complete respiratory support system that's portable, that allows Jesse to be on his own without the benefit of an attendant for any kind of respiratory support.
Great. So all of this equipment is really designed to give Jesse the most independence possible. Is that right? Let's take a look at some of that independence with a video of Jesse at home.
Choosing to use the vent was a conscious decision. We had to say, yes, we want to try this. And it was new technology at that time. So when we got it and we saw how successful it made Jesse, we really embraced it wholeheartedly. And I just can't imagine life without it. It allows him to maintain independence and allows him to really maintain his health and quality of life.
After high school, I decided to go to college, just like any other normal teenager. And at the time, I wanted to go into some kind of engineering, probably aeronautical. And I got into the U, surprisingly, so I decided to go there. And I took preliminary classes in engineering and found out that really wasn't for me. So I started taking psychology classes. And I was doing that, and I thought that was going to be my major. And then I started hearing about a computer program at Bellevue Community College. So they had an open house over at BCC, and I thought I'd check it out. And I went there, and I really kind of found what I wanted to do. This is a group project I did, and here are the credits, and there's me. Here's a map of the city that the city will come out of the map, and I animated this. Not all the animation that you see. I did, however, design the walls for this, but all the different angles you see here, that was on me moving around the camera that you use in the animation program.
The assisted breathing has changed our lives in a couple of ways. Number one, it's kept Jesse independent. But number two, medically speaking, I guess, it's non-invasive. There's no surgery involved in it, obviously. And it's also helped him keep his lungs expanded and open. So he has very few colds. He hasn't had another pneumonia in the last probably 13 years. And that's real critical in terms of his life expectancy and how well he does on a day-to-day basis.
What I'm doing here is using a photo editing program called Photoshop. And I decided to design a guitar. And so I took different body shapes and neck shapes and all the other parts for the guitar, like pick guards and knobs and all kinds of stuff, and then tried them out and picked which one I liked. Once I had designed the guitar, I had a friend who builds guitars and decided that I wanted him to build it.
When I had my heart attack, it was the ultimate wake-up call, and I guess from all reports I was having a hard time in the emergency room. I was not able to relax or calm myself down because I was worried so much about Jesse. I got a call from Linda, and I got to talk to Jesse, and they explained to me that family and friends had gotten together and were taking care of all the care needs that he had. And the breathing was the thing that I thought about the least because I knew how dependable the machine was. He was able to get through that 8-week period of my recovery with no noticeable problems at all.
I think it's good to have goals, and I set them for myself. If I don't necessarily reach them, I don't necessarily get depressed about it. You can set other goals. I don't set them low. I set them pretty high.
Now I'd like to welcome Steve Watson, whom you've just met. Steve, first let me ask you, obviously this is a lot of equipment and setup. How has this affected your family?
Well, there is a lot of equipment. And Jesse's mom and his sister and I, in cooperation with him, managed it pretty well, I think. But we've got a pretty good extended family, and it allows us to spend a lot of time with them. Family gatherings are real important to us. And, with Jesse feeling better, well, most of the time, we're able to do that. You've got some friends that you get together with ever since junior high, and that's pretty neat too. I guess just the health aspect makes it really important.
Him being healthier.
Yes.
Well, I think our goal as a clinic is really to help you be as independent as possible and also to live as long as possible. You know, as you know, both Steve and Jesse, that the average life expectancy only used to be about 18 years old for young men with Duchenne's. You're now 30. What are you planning for the future?
Well, probably I've got to finish my college degree, and then I'll probably look for a job after that, and after I get that settled, who knows? What's great about this whole thing is I don't know. And kind of before you kind of knew where it was going.
Mm-hmm. We're not looking at a particular date, number of years, or an age. We're able to get on with our lives. And as much as we like you and Louie, we'd rather not see you more than once a year if at all possible. So
I couldn't agree more with that. I think that's great. Well, I'd like to thank you very much for spending time with us. I'd like to thank Louie for spending his time. Thank you for watching Talk Medicine. My name is Josh Benditt. Please join us again in the future.
All he's asked for is sort of a fighting chance. This machine has given him so much more than we ever dreamed of back when he was 12 or 13. And he's getting ready to celebrate his 31st birthday. That's a pretty amazing thing. You know, it's something to really be thankful to God for, that he's lived this long and he's a happy, productive person.